Figured I had a good chat with our athletic trainers today. We went over a re shoulder evaluation. Basically, they thought it was the first person thought it was bicep tendonitis, and I did not think so. And we just basically talked about why, like, what my thought process was, what his thought process was as well, and just kind of went back and forth. Um, that sparked into a conversation of what our process is in general, and kind of how we started from undergrad, then what happened, like what changed for you, and then how you basically evaluate now, and what's important to you in I guess any type of evaluation. And then from there, how do you treat, like, what evaluation? This could be a really long topic too, but like what evaluation is important to you of how you treat somebody. So you can do, like a full PRI screen, but the dude still has a bum shoulder, and so it's kind of like, okay, uh, you have to prognose the shoulder first, and then I feel like you go on after that and kind of figure out what it is, um, essentially, like, movement wise, and like some things you can attack and some things you can look towards when you want to make a change, or for rehab wise purposes, or like exercise selection type stuff. What are your thoughts on that?
I think that it's a little bit multifactorial. One thing that kind of jumped in my head immediately, and this isn't always where you should go, but what is going to generate the most buy-in or psychological gain from the athlete? So someone asked me, what percentage of patient outcomes are psychological? That's not verbatim, but more or less, like, how much of your win is generated from the athlete kind of saying, like, yeah, like, I really feel this, like, this was a good day. I got a big win out of that. So, and I honestly felt like it was maybe upwards of 70-80%, and that's just a number we're never really going to know for sure. But a
I'd
part
agree.
of what's that?
That's the first. I would have said about 80%. Like, that's
Yeah.
like what popped in my head.
And so, yeah, going along with the evaluation, you should still value what you're getting from your numbers and whatever's popping out. But when it comes to integrating or intervening, I think a big part of that should always be, what is the athlete going to feel the most, and what are they going to feel like they walked out of the training room with a benefit or a change, or feeling like they had a good session. So,
Yeah.
because there's some things where you're gonna run them through something, and it's super important, or you believe it's super important, and they might not be all about it. They don't really, maybe it's they
Mhm.
don't feel it so much, maybe it's, why am I doing this? This doesn't really make sense to me. So I think that's a part of it. And then also it's kind of looking at what what are the, they say low hanging fruit. That's another buzzword, but what's something that you can get a change out of with relative ease? A quick retest, something that you can check over again and see, like, okay, did this change? And a lot of times the athlete can see it too. And again, that's going to be a psychological win. They're going to say,
Yeah.
all right, look at, if you're doing internal rotation, look how close or look how far you came here. Kind of take a mental image of that, and then go through whatever your intervention is,
Yeah.
retest it again. And then if they can see that physically drop more, again, maybe that's not the source of the problem. But if, as a bastardized example, I think that's something that can be kind of a big win, is those retests that are super easy to do.
Yeah. Parlor tricks, right? Like, making something that can change pretty quickly, can get buy-in, like, really, especially with people who haven't done it before and really haven't used it as a test, or don't understand it as much. You can be like, hey, we just did this one exercise real quick. You gain 30, 40 degrees. Like, they're all of a sudden all the way in. Like, they see it, the big difference, as opposed to even feeling it. Um, but yeah, so for me to, like, I guess it depends on how we want to go with this topic. Um, I love retest with active motion, and for them to go, okay, like, how do you feel? What's the difference? And um, like, the first time working with somebody can get kind of boring. Whereas we do one exercise, we get up, we test it. How's that feel? Okay, get back to do the same exercise probably 3 times. If it made a favorable change, we'll do that a couple times. Then we'll go to the next exercise, and then test again and see if that made a favorable change. If that didn't, then, or they just didn't know what to feel or didn't know what it wasn't the right one for them, we have to regress it or change postures or whatever it might be. But I think tests, especially, like that's where you need to have time one-on-one with the person, is to go back and forth and test, retest, not just say or assume that, okay, just because he fits this pattern, this compensation, I'm going to give him gap retractions, ER holes, and whatever. And like, this is what he needs. This is going to be it. Because it might not, right? They might, like, they need to have a say in the topic as well. And it gets that buy-in. Like they need to be part of it, part of the decision-making process. So here, I'm asking this because I feel like this can be a super long topic as well. If we keep going down this rabbit hole, but like, what's your process to evaluation? So someone comes in, back pain, shoulder pain, doesn't matter. What is where do you start? Where do you end? And then what do you use to determine treatment?
I don't know that it's anything super fancy, but the first initial assessment is going to be the longest, and I think that's fair, so that you make sure you're not overlooking things. And then as you move along, you're going to start to notice certain things as maybe abnormal or far in the spectrum of, this is a lot of range, this is not very much range, if that's one of your metrics, or if it's a special test, or if it's strength. I mean, you really have to have that solid backing, especially if you're going to be talking with doctors. I mean, they don't really care what a PRI test says, but definitely get the orthopedic thing down, and then kind of narrow in on a few things. Like, I think that's the thing about SFMA. It's a good system, and there's a lot that goes into it. But I'm not going to SFMA someone every single day. That's not really realistic as far as time goes. So I think that's where you hone in on a certain thing, to where I think, okay, back pain, it's typically we're going to look in hips or that localized area, and then kind of spread out as we go. And so I'll just try and look at the different planes of the hip and the back, and rotationally, just seeing how they're rotating through their spine, and if they're integrating their hips. But again, I don't know that it's super in depth, or something that nobody else does, which I don't know if that's necessary. But I think it's basically get the whole information first, and then take a step back and look what are some different routes that I can attack, and get some consistency before you just start jumping all over the map.
Yeah. I think that's where it comes down to. Like, I've been guilty of it for sure, where you're testing a shoulder and like, oh, in my head, like in school, I'm taught instability tests, like palpation of bony structures, palpation of soft tissue, active range of motion, passive range of motion, or vice versa, strength, and then special tests and like instability tests first, and then like you check everything else and just go down the line. And I feel like if you do that, it's just a lot of table acrobatics, and it's not as like time efficient. And so I say now it's almost where like I see what's wrong, like where I have them point to the area. If it's something simple like an elbow or hand or whatever like that, like they're gonna be on the table anyway and they'll do it. But like the shoulder, for the most part, they're have to be standing up first and kind of telling me about it. I don't really. I'll poke. I'll touch where they say it hurts, just so they're aware that I'm touching the spot to begin, and then from there, I basically just have them go through like active stuff to see what, like you used to talk about ranges, like see what ranges, if anything, bother it, and then from there do some special-ish tests and just some movement type stuff. Standing up, just like the easy strengthening that I can do standing up, because I think that's definitely telling. Like seeing in someone ER strength standing 990 and then having them test on the table where now it's not quite with gravity, and then you can control and put them in whatever plane you want and stuff like that, and change the vector of where you test at. And so then you give them a table and start touching and being that goes back to the conversation I had at the start. They thought it was bicep tendonitis, and then finally if you got them on the table, they got them relaxed, and you can move the humerus around a little bit and you poke, it'd be more greater tubercle. And if you just put like a broad finger on something, you would say, yeah, it's bicep area. I mean, it's got to be the bicep. And so like you would poke on the greater tubercle, that would be the exact pain. That's what he said. Is like, that's exactly where I feel it. And then like with one finger, I can keep it there. The other finger, I can play around with the bicep tendon. You go, how about there? It goes, nah, not so much. And so for me, that was like my first clue. Okay, it's probably not bicep tendonitis. But yeah, then you can, from there, you can change your vectors on strengthening. So you can do like end range strength, super end range, I guess, at both ends. So shortened and lengthened, and kind of see what the difference is. A lot of times they can relax a lot more, so you can get more of a true stuff. And then like you were talking about, just a sound and anatomy and sound physics with it. And you kind of get a good idea of what you're dealing with before, like for me, that's what I do first before I kind of attack what I want to do. And soft tissue too, not in the sense of you can look for tone and whatnot around the area, but I like looking for trigger points. And so that kind of threw me more into what his issue was when I touched pec, just tight, no referrals. Subscap wasn't too bad. Supraspinatus, traps, stuff like that. Everything was just tone, basically just toned up. And then when I got him on his back and I played around with the infrastinatus, that kind of that shot right to the spot that he felt. And so that kind of, for me, that further proved my testing. And I don't know if, I can't say like that was it for sure. Like this could be an incidental finding, but at the same time, it's like, it just seems too odd for me to have all these things that point to infraspinatus. And then when I push on the infraspinatus, it referred to that right to the area. And so that's kind of, okay, so am I confirming a little more that this is more towards the issue, at least.
How many times do you think that the area you're pressing is, if it's mechanoreceptors or just nociception in general, that's not necessarily indicating the site of injury, but it's basically just a highly sensitized area? Could that be misleading at times?
Oh, for sure. Because I mean, if you look front of the shoulder where the bicep tendon goes, I mean, if you look at Travell and Simmons, like referral pain guide, there's 15 muscles that can go to that area. And so it's not always going to be that. And sometimes there'll be a spot that's super tender, but doesn't refer anywhere. It just stays localized. So yes, I mean, definitely I would use that alone. Like by pushing the infrastinatus without doing anything else, I would have said it's too low for me, too low of a chance that that's going to be the issue that's going on. But combination of everything else is just another confirming for me. Like I'm not in a standalone. That's not what I would rely on.
Yeah.
Just so happens I thought it was interesting that I pushed on that and that referred over. And I'll be honest, it's kind of the first times I started doing that.
Mm-hmm.
I haven't really done that too often where I start checking all the structures around. But I just did just to kind of like humor myself, or maybe I was in a teaching moment and it kind of just popped in my head. But it was cool. Like just the fact that it was kind of confirmed. Like I had an idea in my head, my testing confirmed it, and then when I played around with that muscle, it elicited the same spot he was having the symptoms with. And so I just thought that was cool.
You can't let your confirmation for what you're looking for make it turn into confirmation bias, though, right?
Yeah. And so that's why I was like, let's just try this. So like I had, like if I had to make a prognosis, after doing the special test stuff, like okay, or doing my testing, I was like, this is probably what it is. And then everything else was just for shits and gigs. So I was just trying to look and see. But it was just cool. Like sometimes just play around and you find some stuff like, oh, it's interesting.